Um, what we really hope to do today is highlight in all the ways that we, wherever we are also part of the globe. And actually, our global health practice is very similar to our practice in palliative care. There's a lot of the same principles that apply in both areas. So this quote is written by a global health practitioner, but I think could have just as easily been said by someone who practices in pediatric palliative care. So what he says is he's talking about humility and specifically really hearing the patient and family and community's perspective. And he shares humility is that uneasy awareness that you are in many ways still an outsider. You do not have the full context or lived experience of another being, and you do not have all the right answers. Humility is the feeling that should make you pause and listen before fully contributing. And I think in palliative care, we teach taking that moment to pause, using silence effectively, really listening to patients and families, respecting their lived experience. So I think as you're hearing the talk today, holding that idea in our heads that so much of this applies to both palliative care and global health. Actually, you'll hear concepts that sound very familiar, concepts around bearing witness, especially in times of uncertainty or unavailable resources to fix a problem, having cultural humility, recognizing that our perspective is only that, it's only our perspective, and really being open to the perspectives and the experiences of others to help inform what care looks like, what problem solving looks like. When we think about partnership, it's how do we trust that the person or the community that is our partner holds expertise about their problems, holds expertise about what they think the solutions should be, and how do we really listen to them first before jumping in and trying to solve. And then this idea of what does advocacy and allyship look like in both palliative care and in global health. Um, Many of us are often in the positions where we're holding a lot of power. And so, what does it look like not to show up as a savior, pretending that we have knowledge and resources and are going to step in and rescue, but really, what does it look like to approach that relationship from a perspective of listening and humility? So, you're going to hear that from both of our speakers today. We're so excited. I'll introduce them both, and then Kamara will speak first, and then Regina. So Kamara is a nurse practitioner and a play therapist at Connect Place Children's Hospice, and also a director with Two Worlds Cancer Collaborative, which does work with healthcare professionals in South Asia, really around teaching and mentorship as those healthcare professionals in South Asia build programming to better support children with serious illnesses and their families. Regina is an associate professor of pediatrics and works in both pediatric ICU care and in pediatric palliative care, and is a native of Guadalajara, Mexico, where she earned her medical degree, and then pediatric residency at Rush in Chicago, and then critical care in Houston, Texas. And has extensive experience in global health, which she'll be sharing with us today. And with that, I'll pass it on to Kamara.
So today, really just looking at exploring global health principles and how they apply to education. IPSE is about how do we teach better? How do we collaborate in a way that makes the learning accessible to us? And I want to just say that since I've done global health work for about 10 years, it's been really part of my life. I have found that it's actually, I don't know, it's changed me. It's changed how I live, and it's actually changed how I taught, how I teach. And I'm hoping that with this presentation, I'm going to give you guys some ideas about how do you apply some of these principles to your teaching at the bedside, to lunch and learn, to an opportunity that you're in front of an enormous auditorium of people. What are some ways that we can really think about bidirectional learning and teaching that global health principles actually teach us? Next slide. So Global health principles, I want to just again talk about the varied history of how global health has come to be. And really, Global Health 1.0 was protection of colonial representatives. That was sort of the focus. It's not to say that everything was bad about how people did global health, and I'm not here to sort of degrade former people that tried to make a difference in the world. But we acknowledge that Global Health 1.0 was very paternalistic and it was more one sided. And, it really was, you know, uh, geared from the colonial powers that came to be. Global Health 2.0, wealthier countries helping countries with less. And so there was a shift where it was like, okay, well, we have more, so how can we help you? And again, it was a little bit top down, right? I see you have a malarial problem, and I think this is what we're going to do, as opposed to hopefully Global Health 3.0, and we're probably still making a lot of mistakes, but to say that we're really focusing on this collaborative action, this action to say, I have a responsibility is coming from this part of the world, as you have um, you have a responsibility in your home setting. And if it's increasing pediatric palliative care, how do we work together in doing that? And all of it comes from a wheel of equity where we want to partner authentically. There's inclusion, humility, shared benefits, a commitment to the future, and a responsiveness to the causes of inequity. So we have to, that's our base in which we work. Next slide. I think there's concepts that are helpful in changing population health that again helps us in how do we build out our education practices. And I'm going to talk about a few of those. But when you think about having strong foundations in your connections with other people across your healthcare settings, whether that's globally or even in a community health foundation where you're saying, well, this child with pediatric palliative care needs is going from hospital to home. What are my foundations? Who do I collaborate with? How do we learn together? This might be an adult palliative nurse that's taking care of a 2-year-old with a brain tumor. How do we take her learning and what she knows about palliative care and brain tumors and pair it with my background in working with children? So again, this theme of using this foundation, these concepts of global health and population health to make us better teachers. Next slide. So if you want to write in the chat or raise your hand, we have a small group today. I think I just want to ask people, what do you believe about palliative care education and how it should be delivered? Who should it be from? Should it be from a pediatric palliative care physician that's been practicing for 10 years? Or what about a fellow teaching a group of people? What do you believe about care in different settings from your own? The idea around, where we come from and our biases is really, really important. I grew up on a farm and I live in a very, very urban setting now where most people have not ever been on a farm. And I know that I have biases when I see families that have a similar background to mine, that grow big gardens, that have a root cellar, that, you know, so what is your bias? Do you think when a child is sent to a small community that they can do it or can't do the care? What makes an expert? And who do you currently share the podium with when you teach? These are really important concepts. And I'm going to reflect a little bit on, again, the organization I work with, Two Worlds Cancer Collaboration and the Sunflower Children's Network. And we are a group of people, mostly from Canada, that have some expertise. But we partnered with a group in India called Pain Relief and Palliative Care Society to actually teach together and advocate together. Next slide. I love this picture. So this is a pediatric palliative care, adult palliative care expert, program lead. She started the Pain Relief and Palliative Care Society. She is amazing, Dr. Gayatri Palat. She is probably one of the most incredible humans I know. But look at her sitting with this family. It actually makes me want to well up because she looks at this dad and this child as someone who's going to teach her something. She sees that dad as the expert in this child's care. And that is where we begin with education. Acknowledging that we can be taught by someone else. And so this is where we should start. Recognizing expertise in others before we share our expertise. And meaning collaborations mean that you have perhaps a hub of leadership where you acknowledge that you have education to share and deliver. But then you have a plan of how you're going to increase that education, increase that support so that your learner can be self-sufficient. Your learner can do advocacy, that your learner has the resources to do further teaching, that scope is increased, and that the curriculum that you develop is both general and specialized. And so this is just this idea of how do we meaningfully collaborate to improve population health and palliative care services. Next slide. So reciprocal learning, I put a couple pictures up here because I think they speak louder than my words. But there we are in Hyderabad at the adult hospice and children's hospice that Dr. Gayatri founded. And we're doing serious illness conversation training with this group. Dr. Peter Louie, who is one of the physicians I work with at Connect Place, and I went to India to spend time. And I love this picture, everybody leaning in and learning together. And we took the serious illness, the guide that we adapted from Erdyandy, and we adapted it to our setting. And then we actually took it to India, and it's now in Telugu. And we worked with this group of people to say, how does wish, worry, wonder work in your language? What words work for you when you share to a family that you hope to with them? When a family says, I understand my child's got the cancer's worse, but I hope she gets better. She's going to beat this. What in your language would have that connection that you say, I hope that too? And how would you say in your language, but I worry that no matter all the things we're doing, that she might get sicker? And so we worked together to create the guide that would work for them in these serious illness conversations. And I think one more, sorry, back, Tanya. The other thing I just wanted to say is standing before you in actually Canuck Place in Vancouver is a nurse from India who has been a strong, strong lead. He makes very minimal money. He cares for his family and for a time lived 12 hours on a bus away from his family to support. And he's a profoundly intelligent man who has done so much. And when we went and worked with him in India, we said, Dr. Gayatri, do you think Swaroop could come to Canada and teach us? And this is an opportunity that would never have come to him. And so when I say, who do you share the podium with? I think of that often, that is there someone else that you can bring to the podium that has differing experiences than you? That you can see his slide, the chronically and incurably ill. This is language that's used in India, not really here. But what an amazing session he gave to actually talk about the experiences he has in caring for dying children. And how brave of him to come here and be in our setting. Next slide. So applying the health principles that I think we do really well. So one of the things that COVID did for us, I think in a positive, is that it opened up virtual teaching and virtual patient consults and virtual this and virtual that. There's downsides to virtual, but there's a lot of pluses. And so we do a lot of echo sessions in our Two Worlds work. We do a lot of teaching in our fellowship program through Zoom. And I always say to people, oh, I want to come and help in global health. I want to come and teach. And I say, great, we would love you to come. Why don't you audit and be an observer first? This is a really good educational principle. Before you jump in and teach, see how other people are teaching. Particularly when you're working with maybe populations you don't understand their living conditions. I've seen too many times someone jump onto a global health echo and start teaching and talk about all these great medicines, methadone, and why don't you try this and why don't you try that and all that. And you realize that they just got access to liquid morphine 2 years ago. So show up as a learner first. Do your research. What is available? What is current practice? How do you address people? What's the time zone? That's a big one, right? Even in our big US and Canada, right? I love when Toronto tries to schedule a 7 a.m. meeting for Vancouver and it's 4 in the morning here. So know your time zone. Ask before you answer. Isn't that always such good practice in pediatric palliative care? Why is my child having shortness of breath? And before launching into that, you say, tell me, what do you think is going on? Such a good education principle, isn't it? Be explicit about also being a learner. Start with that. I am here coming from my very well-funded program in Canada. I have all these resources, but I need to be humble and I need to say, actually, you're going to teach me so much. The volume of patients you see, the different issues you manage. Please teach me as I share with you some of the things I know. Understand what the learner's hopes are. This idea of needs assessment in your teaching comes through, particularly, I think when we are working with learners that we're not sure where they're from or what they already know. And I think this other idea of do not pity, but acknowledge the disparities and unfairness. I think we have to put it into the circle that things are different and that it isn't fair, that the world looks as it does. Next slide. So make a plan, and I always say make a plan, and if you're in Nepal or India, make it over food because the food is so good. So these are two of our partners in Nepal. On the right is Dr. Biplav, who actually was our fellow. He's a pediatrician who took the fellowship for a year with Two Worlds Cancer Collaboration, and then his co-worker who is a medical oncologist, pediatric medical oncologist, and we were having a meal and kind of deciding what our training day would look like. So I offer an example of a lesson plan to all of you. This is from the work in Epic Peds. So probably many of you know about it, but we as very experienced teachers, as many of you are, I always say, go back to this, go back to really thinking about who's your audience, where will you teach, what will you be teaching, and how will you teach. Next slide. And then the where, how, who, considering all of these things, does the learner have access to the learning opportunity? I think in our own countries, we realize that trying to get nurses or child life or other disciplines to different conferences or opportunities looks different than physicians. So we do have to acknowledge there's disparities within our own systems as well. And so who are you teaching and how do you get them there? Who understands the worker's work environment, role, power hierarchy, and resources? We know that sometimes just having an echo for nurses allows them to speak differently when there's physicians in the room. There's a big hierarchy in India about who can say what and how. Even having some of the sister leaders in the group can actually squash conversation. So be aware of that in your teaching sessions, even locally. You know, what is the power dynamic? Because the learners need to feel empowered to speak and give feedback and examples. And then this idea of who's the right teacher. It's not always the one with the highest title. It's not always the one that does, sometimes doing a pain and symptom management talk shouldn't be from a physician. It should be from a nurse at the bedside. So who is the right teacher and how do we bring that? The picture I show you on the side is this is a ward in Nepal where they do not use conscious sedation or any pain medicine for bone marrow or for LPs. They hold the child down and they give them a treat after. And we were able to, on one of our trips, institute a ketamine and protocol where they and some morphine pre that worked extraordinarily well. And this little girl and her dad were our teachers, and these nurses were just so thrilled to be able to provide conscious sedation. The physician was so on board, and we normalized it and created not only a protocol, but we got a little bit of micro funding. So, because the parents had to pay for the medication because it wasn't covered. So we got a micro grant so that we could be able to provide that medication cost. So, yeah, look to your teachers. And we were not thinking that that's what we were going to be doing when we were on that trip, but that was one of the successes because we looked for an opportunity to teach something that they really wanted. Next slide. And then choosing your format to increase access. I think in-person seminars, just-in-time learning, always consider, is this the best way? This might be the best way to kind of get that application of practice using virtual echo sessions. And consider co-facilitation. We find it's really helpful when we're doing global work to have, yes, you have your North American that might be co-facilitating with someone who's presenting from India or the Philippines or wherever that might be. But that partnering is just such a good example. WhatsApp and messaging, be comfortable with being using other platforms that you might not think about in sort of a North American context, but inviting a group on WhatsApp to say, hey, share not patient details, but certain scenarios that you need help with, are you converting a medication that you want a little bit of advice from? So creating messaging apps to do teaching just-in-time teaching is really excellent. We also have the availability for our fellows to do one-to-one calls for us, with us. And what's kind of cool about having all different time zones, I had someone that was worried sick at 2 a.m. that she didn't do the right thing. In her practice that day. So she called me and it was 2 p.m. here. So it was perfect timing. And so that idea of collaborators across the globe is really good. And I think that's my slides. Any thoughts, questions, or considerations and all of that? I see Jody is on, and Jody does a lot of global health connecting too. So love to hear from anybody, their experiences or any questions.
I
Put you on
really
the
love
spot, Jody.
I really loved your talk. Thank you. But also just learning from them and seizing the opportunity. Sometimes we go with our own agenda. This is what I'm going to teach, and what they actually needed was a type of protocol, and just to really be flexible. That's a big thing, and empowering them. And I think that's the way change happens. It's not you go and you dump the information and then you're out of there, but so that they can duplicate and teach. So that's cool.
Yeah, thanks, Jody. I know you've done a lot of work with nurses across the continent of India, and it's just so each time, don't you just learn something, right? You just, yeah. Yeah. Other comments before Regina starts? Or we can wait till the end as well.
Good afternoon, everyone, and what a lovely talk from Camara. Really inspiring. And I would like to thank the association for inviting me to present the topic that is so near and dear to my heart. So we know that approximately 21 million young people, defined as those below the age of 19, experience serious health-related suffering, particularly towards the end of their lives. And we know that maybe 20 million of these patients require primary levels of palliative care, but 8 million would benefit from specialized palliative care. We know also that 98% of these youngsters live in World Bank low and middle income countries. And we're guesstimating that maybe 3% tops have access to pediatric palliative care, especially specialized levels of palliative care. So that's a real tragedy. About 10 years ago, the World Health Assembly came up with Resolution 67.19, where member states were called upon to develop, strengthen, and deliver palliative care to patients of all ages, children and adults, as an essential component of universal health coverage. And the concept which they published in 2021 was to acknowledge that a very large population in the world has palliative care needs, and that the way to provide coverage for these patients is through education and training, particularly in the use of essential medicines, through research that helps inform health policies and empowers people and communities, so that at the end of the day, palliative care services can be provided in an integrated fashion to those who need them the most. So where are we 10 years later? And Richard Harding and his colleagues came up with a report just a few days ago, actually. And it was a joint effort between the World Health Organization and the World Innovation Summit for Health in Qatar, where they really are concerned about the limited progress that has happened in these 10 years. There have been some positive interval developments, and we just saw an example of the slide that the World Health Organization published in 2021. But very little progress has been observed. And to make matters worse, we had the COVID-19 pandemic, which is still unfortunately active. But what is recognized in this recent report is that there's an urgent need for action to meet palliative care demand in patients of all ages, including children, and especially in low and middle income countries, because we know that in the decades that follow the one that we are living in, the number of palliative care patients of all ages, including children, is going to grow very significantly. And the number of providers is going to lag far behind. So lots of challenges. Some of them are natural and some are man-made. We know that countries with limited resources sometimes have trouble meeting the basic needs of their citizens, in terms of food, safe water to drink, um, shelter. We know that many of the components of the World Health Organization essential medicines lists are missing or go missing or stock out. We know that we are at historic levels of forced displacements worldwide. We know that climate change has increased our vulnerability to natural disasters, and we know that we are living in a world that is on fire. And anything that threatens an adult threatens a child even more. We know that a lot of children are living with the sequelae of the COVID-19 pandemic. We still see kids in our own hospital, which is one of the best resources in the world, coming in and dying of COVID. But we know that there are millions of children who lost a parent or a grandparent or other supportive figures in their family to the pandemic, and that their own home economies were changed drastically as a result of the pandemic. We know also that tragically there is a tremendous inequity in availability of opioids and other essential medicines, particularly in child-friendly formulations. And this map was published by Felicia Nall and her collaborators in Lancet approximately 6 years ago. And, I think things have changed very little. We can see that the United States and Canada and Australia are really bloated with opioids. And this is an epidemic of a very different sort. But for instance, I am from Mexico, and in response to the opioid epidemic in the United States, the government of Mexico made a decision not to purchase pharmaceutical grade morphine 2 years ago. And so on any given day, there were 60,000 patients dying in pain every single day. They even went to the extreme of prohibiting the use of fentanyl in the operating rooms by anesthesiologists. So we see, there is a tremendous amount of inequity in opioid use throughout the world. And these are medicines that are safe and effective and vital to our patients. Fortunately, we have a lot of palliative care organizations for children and for adults. I've mentioned some of the initiatives with the World Health Organization. St. Jude's has a huge footprint in global palliative care, as well as other academic centers throughout the United States and Canada. Pal Chase is about 7 years old and focuses on patients with palliative care needs due to humanitarian disasters. The International Association of Hospice and Palliative Care and the World Hospice and Palliative Care Association also work closely with the International Children's Palliative Care Network, which is the organization that I work with as the representative from Latin America, to try to network and mitigate these very, very significant disparities in palliative care on a global level. We now have probably 4,300 individual members in 430 organizations in the United States and throughout the globe that are members. And I would encourage you to become a member. And you will see this QR code, which I will post in another one of my slides so that you can catch it and read the most recent newsletter. And it's all about caring. The strategic focus of ICPCN is based on communication, advocacy, research, education, and strategic development. And this all resonates with what the World Health Organization is trying to do worldwide. And you will see, if you click on the QR code, one of these really nice slides that ICPCN came up with just a few months ago. And it looks very much like the concurrent care model that we have in the United States. And really, it tries to integrate holistic symptom management and care planning with strategies that are directed at disease management and palliative care. We know that some of our patients are not able to survive, and we focus on bereavement. But now we are starting to see more and more survivors of malignancies and other disorders, and we also have to regroup and support these survivors. I read just today that a significant number of young male long-term survivors of childhood cancers actually end up with severe depression and end up taking their own lives. So this is something that we really have to focus on. ICPCN offers in-person training throughout the world. There are e-learning modules that have been translated into 9 different languages. We have briefing papers, which came out during the COVID pandemic. We have been able to participate in important articles. We have book chapters and books that we hope are useful. And actually, we have a webinar the day after tomorrow at 4 p.m. UK time, which will be given by Dr. Stefan Friedrichsdorf, and will focus on chronic pain. We have conferences around the world, and we are constantly mapping the world as more palliative care programs come together, or because of circumstances, have to close down. And we saw that happen during the pandemic, and even before then, for instance, in Venezuela, because of how unstable the country became. Sorry. The idea is really to bring all worldwide networks together. I was very pleased to see the slides with Dr. Gayatri. She is just a phenomenal person. She's such a sweet person. And she is also one of our international board members for ICPCN. And the idea is, once again, networking. High income countries have a lot to learn from the way low and middle income countries operate throughout the globe. So, because, we all have something to learn and something to share by being humble and open-minded. And we have global palliative care clinician champions worldwide. If I tried to list many in our own continent, I would miss out on many. So I'm going to focus instead on my 2 friends, Father Rick Bauer, who is a chaplain and has done tremendous work in Africa, really bringing the AIDS epidemic under better control. And now we have Dr. Megan Doherty as our representative, living and working with the World Health Organization in Geneva. So that is going to be extremely helpful to pediatric palliative care moving forward. So future directions, I think it all boils down to networking, education, and strengthening our palliative care throughout the world so that we can make it a much better place. And after all, sharing is caring. And I would like to thank you very much for your kind attention.
We'd like to thank both of you. That was extraordinary. We'll open it up for questions in just a second. I think in both of your presentations, you highlighted something that feels so powerful. I'm not going to say it as well as you did, but it's sort of this idea that it's not about an us helping them. It is about all of us out of a shared sense of like a shared sense of humanity, helping each other, and that children, wherever they are in need of help and care, and their families, that's not restricted by borders, and we can receive help and we can give help. And if we can do both, we should try to do both. So I really appreciated your presentation. With that, I'll open it up. Any questions for our speakers, or if you have any of your own experience to share?
Can I jump in? Great. So thank you both for your insightful presentations. My name is Jasmine, and I'm the new clinical comms officer at Canuck Place. My background is in global health. I received my master's in global health and have been working internationally on many different health projects. So I really want to applaud you both for implementing such a collaborative approach to your work. The importance of cultural context and local engagement while implementing these projects is absolutely crucial. One question that I have is, how do you ensure that knowledge and practices from local healthcare workers are effectively shared with other regions or other international partners? And how can we better facilitate this exchange of knowledge to strengthen the global pediatric care efforts? Thanks.
Regina, do you want to start?
Yeah, so I think that we've been very, very fortunate that Joanne Wolf and her group at Harvard started PCEP and then Epic Pediatrics. And these are, obviously PCEP is taught in Boston, but Epic Pediatrics has now been translated into many languages and is taught around the world and is periodically updated. And then Project ECHO, I think, has been very important. And I know that it is used extensively in Mexico and in Central and South America. And I'm sure that the content is revised periodically. We also try to make sure that practitioners have opportunities that they might not have otherwise. For example, the pediatric pain masterclass that Dr. Friedrichsdorf leads now in San Francisco hosts international clinicians from developing countries with full scholarships, and sometimes covering their other expenses. And I know that Justin Baker does similar things through his programs. And now that he has transitioned to Stanford, there are several wonderful clinicians, Dr. McNeil and Xiomara Garcia, who will be, just phenomenal at expanding the knowledge and the experience that is needed in the developing world, not only in the Americas, because actually Latin America has some tremendous champions, dating back 40 years. Ruti Kiman, who some of you may know, Mercedes Bernada, just not to mention others, have been very, very helpful in disseminating knowledge throughout the Americas. There are some pockets like Bolivia, Paraguay, the Guyanas, many of the Caribbean countries where we need to really double down a little bit more and bring more palliative care knowledge to those areas. But Africa has just a thirst for knowledge, and those networks within the African continent and the networks within India and Asia and the Pacific region, are really, really coming on board as global palliative care champions.
I might combine two comments that came up in the chat. One was Chuck's very sound reminder to not do parachute medicine, and really instead look to cultivating long-term relationships where both partners' needs and voices and hopes are really heard. And then Elaine's question around, when you're retired and you have all of this knowledge and maybe a little bit of time to be able to contribute, what are ways as an experienced palliative care practitioner that you could contribute? And I'll say, I think that could range from helping folks develop research careers in settings where maybe research doesn't get as much time and space, or writing grants or symptom management. So any ideas that you all have on how folks could get involved in sustainable and ethically sound ways?
One of the ways that HPNA, the Hospice and Palliative Care Nurses Association, was looking at is to do mentors, especially, Tanya, as you mentioned, for research. And we were looking for people that would be mentors in that. Of course, you have to be culturally aware, all of that, things that we've talked about today, but it is a way that people who can't travel or don't want to travel would help out.
Yeah, I think I would just add that I think you have to think about, Elaine, what you want to do. Is it teaching? Is it traveling and teaching? Is it, is it grant writing to raise funds? Often clinicians, though, want to be engaged in what they, patient-facing engagements. Is that something you want? And find people that you are inspired by, and where do they work? Where do they volunteer their time? And I think that's what happened for me. I met a physician that joined the Two World Cancer Collaboration early 2000, and I was a busy young mother and working full time. I couldn't do it. But here was this person, and I thought, oh, I'd like to do what he's doing. So I would encourage you to look at that. We've mentioned a couple organizations here, and I think you can, look into those in terms of what's their volunteer profile look like, how do you apply? So that would be my encouragement. And Jasmine, I just would say one other point to Regina's is that, we offer a lot in North America, and people can come to trainings and do that. But I think what our research shows is that it doesn't always get disseminated back, or the application of practice doesn't always happen. And so how do we be responsive to people who have time and energy and resources to do the training, but then how do we help them, or how do we engage with them so that spread can happen? Because I think the spread piece is actually really hard. And So again, I'd go back to what's your collaboration with the people on the ground that are doing the work? And what collaborations can happen so that this spread and this application of good practice can happen. And it's fascinating. One project I'll just mention in Bangladesh that our organization's involved with was there was all of these people in the refugee camp that had no work. They couldn't work because they're not allowed to work in Bangladesh. They're Rohingyas, and yet they had all this time and no purpose. And so there was a project where people were trained to provide basic care to seriously ill children, to support the families in doing that. And we thought, oh, is this a good idea or not? And it was an amazing practice because it changed the community. There was a bit of a stipend. These people got some money through this grant. They were able to feel purposeful. The children improved. The symptoms were more managed. And again, would that work downtown Vancouver? No, it wouldn't, because we wouldn't allow, we couldn't do that. There's so much regulation around. But what does the community want and need? And how do you support? And so it was offering some basic courses right in real time, and then these led by community activists and community people. And so I think you just have to be really thoughtful about how do you spread and what are you spreading in terms of practice in pediatric palliative care. Naomi, you've had your hand up.
Um, yeah, so first of all, thank you so much for this really interesting presentation. Um, One of the ways where we have ongoing learning in palliative care is through going to conferences and having been involved in organizing conferences, particularly international conferences. What has come up is that many times international conferences, if they're in North America, they tend to be international because most of the presenters are from the US and Canada. If they're European, they're kind of from Western Europe. And so it was hoping to kind of pull the wisdom of this group to think about how can we decrease barriers and make sure that the learning in these international conferences is truly international and that we give opportunities to people from different countries to present and share their work and participate, to teach everyone and participate in the wonderful conversations that are going on. Please give us ideas. Let's talk.
Yeah, again, you've just got to be so conscious of like what's your motivation and who's directing it, and where does it come from? Like what's the hope in all of that? Um and who's it being informed by, right? So I think when we have frank decisions about if we gave you a spot at a conference and you were able to speak and talk about your program, you know, how would that be? How would that be for you to do that? Is that something that, is that opportunity something that is worth their time and energy? And so when you think about a conference board, I think you have to have multi voices on there around those things that we talked about in my presentation around humility, collaboration, shared voice, acknowledging the inequities. But to what end? To what end are we hoping for the inclusion in, if we're just talking conferences? What is the hope, and is our hope the same as the person we're inviting's hope? And even if we can provide the funding for them to come, is that the best use of funding? They might say, well, actually, if you're going to fund this, it costs $5,000. I'd actually really like that for my hospital. Do you know what I mean? Like it's this sort of conversation that we have to have. We have to be, they're like serious illness conversations. We have to be better at these conversations about what is it that you need and what is it that we need, and how do we work together to promote this practice? Regina?
I've I work very closely with clinicians in Mexico and in South America. And the clinicians that are selected to attend the pain master class and the program at Mercy Children's for medical ethics are all very carefully vetted. And so I've been able to see what they've done with the training, and it's just incredible because not only are they going back, but they are becoming really the leaders in the field. One of my mentees, who happens to be from the same city that I'm from, Guadalajara, went on to become the program director for one of the biggest fellowship programs in Mexico, and one of the biggest pediatric and adult palliative care referral centers in the country. So I think people are very mindful of who they are inviting up to participate in these very important programs, and it has a very important trickle down effect. And I don't know if you are familiar with the Maruzza conference in Rome, but it happens every couple of years. My colleague Jared was just there and was a superstar. But anyway, there's like a sliding scale for attendees who come from low and middle income countries, to help them with the fees and to make this really an inclusive experience for people who otherwise would not be able to do it.
Mm.
Like like the clinician from Nepal that was hosted and came halfway across the world from India, from Dr. Gayatri's program, came halfway around the world to your own program in British Columbia. I think people are very mindful when they apply for these opportunities, and very mindful when they select the best candidate.
I think we're at time, but thank you to both of our speakers, and thank you all for attending and for engaging in this conversation. And we will see you in the new year. Is that right, Naomi?
Yep, on Tuesday, January, our next session, bring up my calendar, January 21st, 2025. That seems like it's a really long way away. 2025 is around the corner. Yeah. Well, have a wonderful afternoon, everyone.
Thank you.
You're late. Thank you so much.
Thank you.